Okay, hello. This is Dr. Kamel again, and this is Medical Terminology 2. So, what we have today, essential fructose urea. Okay, what is essential fructose urea? Fructokinase deficiency, so this is an enzyme which is deficient, will increase fructose. Hexokinase pathway converts fructose to fructose 6 phosphate. Okay. Classic galactosemia, galactose 1 phosphate uridyl transferase deficiency. I know that all of you like biochemistry. Accumulation of toxic substances, galacto galactitol in eye lens causing cataracts. Okay. Galact- galactokinase deficiency. Galactokinase deficiency lead to increase in galactose. Aldose reductase convert galactose to galactitol. Cataracts, retinopathy, neuropathy, peripheral neuropathy, and diabetes mellitus. These all complications as a result of excess glucose. Too much glucose in bloodstream, okay, will lead to these complications. This excess glucose will be transformed into sorbitol via aldose reductase. This is the enzyme, and sorbitol to fructose via sorbitol dehydrogenase. So in lens, retina, kidney, and Schwann cells, they lack sorbitol dehydrogenase. They lack this enzyme. What will happen? Intracellular sorbitol accumulation. So this first step is happening, second step is not happening, lead to osmotic damage. And this osmotic damage is the cause of cataract, retinopathy, neuropathy, peripheral neuropathy, and diabetes mellitus. So these are the cause of these complications. Recurrent Neisseria bacteremia, this is bacterial infection. Terminal complement deficiency, we have what's called the complement system. It is a part of the immune system. C5, C9, then failure for membrane attack complex formation. Okay. Hereditary angioedema, C1 inhibitor deficiency lead to unregulated activation of kallikrein with increased bradykinin and lead to the signs and manifestation of hereditary angioedema. Paroxysmal nocturnal hemoglobinuria, BIGA gene mutation lead to reduced GV1 anchors for complement inhibitors, DAF, CD55, MIRL, and CD59 lead to complement-mediated intravascular hemolysis. Okay. Reduced haptoglobin. Type 1 hypersensitivity, we have what's called hypersensitivity reactions. So we have type 1, type 2, type 3, and type 4. Type 1, these are part of immunology. Type 1 hypersensitivity lead to immediate in-minute reactions. Antigen cross-link IgE on mast cells lead to degranulation. So this is a mechanism. Release of histamine, tryptase, and leukotrienes. And late, so we have immediate effect in minutes, and late in hours, mast cells secrete chemokines, which will attract inflammatory cells and other mediators, lead to inflammation and tissue damage. Okay. Type 2 hypersensitivity, antibodies binds to cell surface antigen on extracellular matrix. I think ECM is ECM is, yeah, I think it is extracellular matrix. Yes, like I said, lead to inflammation, cellular destruction, and dysfunction. Type 3 hypersensitivity, antigen antibody complexes activate complement, attract neutrophils, release of lysosomal enzymes. Type 4 hypersensitivity, T cell mediated, no antibodies involved. Okay. Antigen presenting cells activate CD4 positive T cells, release of cytokines, or CD8 positive T cells, direct cell cytotoxicity. Acute hemolytic transfusion reaction. Somebody, in emergency or any situation, and they need to transfer blood. So, and then acute hemolytic transfusion reaction happens. This is a type 2 hypersensitivity reaction against the donor RBCs, usually ABO antigen. We know that we have, A, B, O, and AB types of blood. X-linked proton A gamma globulinemia, defect in BTK gene, no B cell maturation, absent B cells in peripheral blood, decrease IG of all class. We have switching of B cells to different IG, IgM, IgG, IgA, and so on. Dijor syndrome is 20 Q11 microdeletion, and Q is the long arm of the chromosome. Failure to develop the third and fourth brachial or pharyngeal pouches, absent thymus and parathyroid. Okay. Hyper IgM syndrome, defective CD4 40 ligand on T helper cells, lead to class switching defect. Leukocyte adhesion deficiency type 1, LFA1 antigen integrin CD18 defect, impaired phagocyte migration and chemotaxis. Shidiak Higashi syndrome, LIST mutation. What is LIST? L-I. Okay, maybe gene. LIST mutation lead to microtube dysfunction, phagosome lysosome fusion defect. Chronic granulomatous disease, NADPH oxidase defect, reduced ROS, reduced, it is reactive oxygen species, I think, reduce respiratory burst in neutrophils, increase susceptibility to catalase positive organisms. Candida infection in immunodeficiency, reduced granulocytes, this is systemic, reduced T cell local. Graft versus host disease, type 4 hypersensitivity reaction, HLA mismatch, donor T cells attack host cells. That's why it's called graft versus host disease. Recurrent Staphylococcus aureus, Serratia, beta specia infections in chronic granulomatous disease. These are catalase positive organisms, degrade hydrogen peroxide before it can be converted to microbacterial products by myeloperoxidase system. And that's it. This is for today. See you tomorrow.